Hey everyone, today I will walk you through the most common complication of neuraxial complication in obstetric anesthesia, post-dural puncture headache. Post-dural puncture headache, PDPH, is a well-recognized complication of neuraxial anesthesia techniques such as spinal anesthesia. It occurs when cerebrospinal fluid, CSF, leaks through a puncture in the dura mater, resulting in decreased CSF volume and intracranial hypotension. It is particularly relevant in obstetric anesthesia, where spinal anesthesia is commonly used for cesarean sections. The global prevalence of PDPH after spinal anesthesia ranges from 0.1% to 36%, depending on various factors such as needle size, patient demographics, and anesthetic technique. In obstetric patients, the incidence is higher due to patient-specific risk factors. Typical prevalence is reported as 1% to 3% in routine cesarean section spinal anesthesia cases using small-gauge pencil-point needles. Up to 10% or more in cases where larger cutting needles are used or when multiple puncture attempts occur. Signs and symptoms. The hallmark features of PDPH include headache that is positional, worse when sitting or standing, improves when lying flat. Pain is typically frontal, occipital, or both, and may radiate to the neck or shoulders. Associated symptoms: nausea and vomiting, photophobia, sensitivity to light, phonophobia, sensitivity to sound, neck stiffness, diplopia, due to cranial nerve 6 palsy in severe cases, tinnitus or hearing changes. The onset of PDPH typically begins within 12 to 72 hours after dural puncture, although it can occasionally be delayed for up to 5 days. In postpartum patients, it may be overlooked initially or mistaken for other causes of headache, such as preeclampsia or tension headaches. Risk factors of PDPH is multifactorial. Several risk factors increase the likelihood of PDPH, patient-related young age, especially less than 40 years. Female sex, especially postpartum women. Low body mass index, history of PDPH, procedure-related, large-gauge spinal needle, cutting-tip needle, e.g. Quinker, versus pencil point, e.g. Whitaker or Sprott. Multiple dural puncture attempts, inexperienced provider, increased intrathecal pressure, labor straining, pathophysiology of PDPH. The exact pathophysiology of PDPH is uncertain, but there are suggested assumptions as described below. The initiating event is a puncture in the dura mater, the tough outermost membrane enveloping the spinal cord and brain. This puncture allows cerebrospinal fluid, CSF, to escape from the subarachnoid space into the epidural space or surrounding tissues. CSF loss. Continuous leakage of CSF results in a decrease in intracranial CSF volume and pressure. Normal CSF dynamics. CSF is produced by the choroid plexus and circulates in the subarachnoid space, cushioning the brain and maintaining intracranial pressure. When CSF leaks out faster than it can be replenished, it disturbs this balance. The loss of CSF volume leads to intracranial hypotension, which is central to the development of PDPH. This hypotension triggers several compensatory and pathological changes. Monroe-Kelly doctrine. According to this principle, the cranial cavity has a fixed volume, composed of brain tissue, blood, and CSF. A decrease in one component, CSF, leads to a compensatory increase in another, blood. Venodilation. There is compensatory vasodilation of cerebral veins and dural sinuses to maintain intracranial volume. This venodilation is thought to cause stretching and activation of pain-sensitive intracranial structures, particularly the dura mater and large venous sinuses. Brain descent and traction. With reduced CSF buoyancy, the brain may sag or descend slightly within the cranial vault, especially when the patient is upright. Traction on pain-sensitive structures. This descent causes traction on intracranial pain-sensitive structures, such as meningeal blood vessels, cranial nerves, especially the trigeminal, glossopharyngeal, vagus. This mechanical stretching contributes significantly to the characteristic headache of PDPH, which is usually postural, worsening when the patient sits or stands and improving when lying flat. Treating post-dural puncture headache, PDPH, involves a stepwise approach based on the severity of symptoms, duration, and the patient's response to initial measures. Below is a detailed overview of the treatment options for PDPH, categorized into conservative management, pharmacologic therapy, and invasive interventions. Conservative management, first line for mild cases. This approach is often the first step, particularly for mild headaches or in the early stages post-puncture. Bed rest. Rationale: lying flat reduces brain sagging and traction on pain-sensitive structures. Effectiveness: offers symptomatic relief but does not shorten the duration of the headache. Hydration. Oral or IV fluids are recommended to maintain CSF production and hydration status. Evidence: may help replenish CSF volume, though effectiveness is debated. Caffeine. Mechanism: caffeine is a cerebral vasoconstrictor. It counters the compensatory vasodilation due to CSF loss. Dose: 300 to 500 milligrams orally or IV, EEG 500 milligrams caffeine sodium benzoate IV over 10 to 20 minutes. Efficacy: temporary symptom relief. Headaches often return within hours. Pharmacologic therapy. When conservative measures are insufficient, or if symptoms are moderate, medications may be introduced. Analgesics, NSAIDs, ibuprofen, ketorolac, reduce inflammation and pain. Acetaminophen, safe option, especially in pregnancy. Combination therapy, may combine with caffeine for enhanced effect. Theophylline. Mechanism: increases cerebrospinal fluid production and acts as a vasoconstrictor. Dose: 200 to 300 milligrams orally. Use: less common than caffeine, but an alternative for non-responders. Gabapentin or pregabalin. Mechanism: modulate neuronal excitability and may help reduce pain. Use: off-label for PDPH, particularly when neuropathic features are present. Sumatriptan. Mechanism: 5-HT1B/1D agonist causing cerebral vasoconstriction. Use: may be used in selected cases, especially in migraine-like PDPH. Invasive interventions. These are used when conservative and pharmacologic measures fail, or the headache is severe and disabling. Epidural blood patch, EBP. Gold standard treatment for moderate to severe PDPH. Procedure: 15 to 20 milliliters of autologous blood is injected into the epidural space near the puncture site. The blood forms a clot that plugs the dural hole, halting CSF leakage and increasing CSF pressure. Success rate: greater than 90% relief after first patch. Second patch may be needed in some cases. Onset: relief is often immediate or within hours. Complications: back pain, transient bradycardia, rarely infection or neurologic symptoms. Sphenopalatine ganglion block. Mechanism: blocks parasympathetic outflow and reduces vasodilation. Procedure: topical anesthetic applied via nasal catheter or cotton-tipped applicator. Use: non-invasive option gaining popularity for patients unwilling or unsuitable for EBP. Epidural saline injection. Less commonly used than blood patch. provides a temporary mechanical tamponade, but is not as effective or lasting. Special considerations: obstetric patients. Epidural blood patch is very effective in postpartum women. Conservative management often started first if breastfeeding or concerned about procedures. Refractory cases may need neurology or pain management consultation. Repeat EBP, imaging to rule out other causes, e.g., subdural hematoma, or advanced interventions. Prognosis. The prognosis of PDPH is excellent with timely diagnosis and management. Most cases resolve spontaneously within 7 to 10 days, even without treatment. With epidural blood patch, most patients experience immediate relief and resume normal activities quickly. The rare complications of untreated or prolonged PDPH include chronic headaches, subdural hematoma, cranial nerve palsies, depression, or delayed recovery in postpartum women.
Take-home messages. For healthcare providers, early recognition is critical. Always monitor postpartum patients closely for positional headaches following spinal or epidural anesthesia. Ask about onset, severity, and posture-related worsening of symptoms. Understand and communicate risk use, smaller non-cutting spinal needles, e.g. pencil point, when possible. Inform patients of the 1 to 3% risk after spinal anesthesia, especially in obstetric cases. Assessment should be comprehensive. Rule out other serious postpartum causes of headache, e.g. preeclampsia, meningitis, venous sinus thrombosis. Consider neurologic exam and imaging when diagnosis is unclear or symptoms are atypical. Conservative treatment. First, encourage bed rest, hydration, caffeine, and simple analgesia for initial management. Most cases improve with supportive care within a few days. Use epidural blood patch when indicated. If PDPH is severe or persistent beyond 24 to 48 hours, an epidural blood patch is the gold standard. Over 90% of patients experience rapid and significant relief after the first patch. Documentation and follow-up record, the anesthetic procedure, needle size, type, and number of attempts. Ensure follow-up for unresolved symptoms and patient reassurance. For patients, postpartum mothers. What you may feel: a strong headache that gets worse when you sit or stand and gets better when you lie down. You may also have neck pain, nausea, dizziness, or sensitivity to light. Why it happens. It can happen when spinal anesthesia causes a small leak of fluid around your spine. This is not your fault and is a known side effect in a small number of cases. How to manage it. Rest, drink plenty of fluids, and try caffeinated drinks like coffee or tea. Pain medicine may also help temporarily. When to tell your doctor. If your headache starts after your procedure and gets worse when sitting or standing. If the pain lasts more than 24 hours, or if you feel very sick or dizzy. 5. Effective treatment is available. If needed, your doctor may suggest an epidural blood patch, which often fixes the problem quickly. It's a safe procedure that seals the leak and brings fast relief. You're not alone. Many women experience this, and recovery is expected with the right care. Always speak up and ask questions. You deserve to feel well and supported. Thanks for watching. If you found this video helpful, don't forget to like this video to support our channel, share it with friends, colleagues, or anyone who might benefit. Subscribe and hit the bell icon so you never miss an update. We're here to bring you clear, accurate, and compassionate content on important health topics, so stay tuned for more. Your health, your knowledge, your power.